Hey everyone, thanks for tuning back into the Echofish podcast. My name is Mikey and I'll be your host today. Meeting up with Global Vision 2020 and Greg. Greg, why don't you go ahead and introduce yourself and tell us a little bit about who you are and who you serve.
Well, first of all, my name is Greg Wiens. I'm the chair of programming Global Vision 2020 for Canada. I've been in the office out of Winnipeg, Manitoba. Also a international development worker with the Evangelical Mennonites, where I set up business projects for poorest of the poor Mennonites, mostly who are in and around refugee camps. And I also serve as a pastor in Canada. City folks. That's what I've been doing for the last 25 years of my career.
That's really awesome. I have quite a bit of a background in eye health myself, as we were kind of talking a little bit before we started here. Tell me a little bit about Global Vision 2020 and some of the goals you guys have and what you guys do, and kind of wrap it up for me. Tell me what's going on there.
Well, I'll try to give you that 2-minute pitch, elevator pitch. We're an organization that started off as a NATO peacekeeping mission project. Our executive director, Kevin White, was in charge of all NATO international, and some of the projects he oversaw were eyeglasses. And he said there's got to be a better way than doing the system. So almost 15 years ago, he was in Mali, and they set up an optometrist. They brought in just crate loads of used glasses, and everything was funneled down to just that one optometrist. So they might see 40, 45 people in the day with this big center that they'd set up with tents, having a bunch of soldiers standing around, nothing to do. And at the end of it, they would rarely get the right prescription. So here's what I mean. They would find the right prescription from the optometrist, again, pretty narrow funnel. And then they would have to sort through all these used glasses, which had just approximations on them. So here's what I mean. When you donate your old glasses, there's no prescription that's on them. They have somebody that sits there with a caliper that tries to estimate what they are. So it's really summed up best in one of the local leaders in the community, the chief of one of the communities just next door to where they were set up, came in. They actually found him the right prescription and glasses he could see 20/20 with that were used, but he didn't want them because they had pink frames. So he left seeing 20/50 because he found frames that were black frames that he liked. And we said, there's got to be a better way. One, there's got to be a way to widen that funnel, so there's more people seen than 40, 50 people in a day. Two, there's got to be a better way to do brand new glasses than used glasses. Because when you start buying new glasses in bulk, they're actually extremely affordable. And three, there's got to be a way to leave the program behind. So let's just say hypothetically, I find somebody who sees 2100, which is pretty bad vision. And it's not uncommon. Every day I get pictures of people who send me from these teams that are around the world, who they walk away seeing 20/30 or 20/20 vision, well enough to pass the driver's test in North America for a large truck. And you've now given them a pair of glasses, but nobody's going to be back to give them a pair once they lose them or break them. So this system is all set up so that it can be done by local healthcare providers in the already existing project. So that's our basis of what this is. It's a lens that goes from a +6 to a -6, positive to negative. And it has the aperture that shows in between where the patient simply puts it on. They turn the dial till they see clearly, find the corresponding lenses in the lens box. In this case, it's a green 1 and a red 4. So I grab the corresponding lenses out of the lens box. Red 4, green 1. And you just simply snap them into brand new frames. These are the exact same frames you buy at any of the Shoppers Opticals here in Canada or the United States. And you snap them in. And all of that takes, when you're doing it in a clinical setup, run by a nurse, looking for other eye diseases and everything else, about 10 minutes and about $4.
That's amazing, because coming from a background where I was training a lot in like refractions and teaching a lot of these newer technicians how to do the lensometry, do the reading the glasses, doing the actual measurement of the glasses prescription, even how to do the old school techniques with retinoscopy where they use, the light, obviously. Well, some people may not know those terms, but, having something as a device like that to be able to break down the components of those machine, or even to use as a standalone device, is going to be a lot easier, because I know in our situation, we did have people coming back for glasses checks, because typically speaking, if you're in diopter terms, half a diopter off on the cylinder of the sphere, it's not going to be a massive issue unless you're really high in the prescription range. And I mean, a -6 to +6, you're not going to really notice that. So this device not only helps that, but it's as easy to use as a cover uncover test. If you think about it, just being able to assess vision and being able to turn those dials and clear it up and be able to get a good understanding, no matter what the language barrier may be as well, is going to be a lot easier at the end of the day than you have to train, the optician, the optician to see those 45 patients, the optometrist, and then you have to train the opticians on how to do lab work involved with grinding the lenses. This makes it to where it's an actual accessible piece for people to be able to get a hold of, because like you said, 2100 vision, I've simulated that before, and it's scary. It is not something that is a very easy thing to see through. So that's really amazing, especially in the hands of staff that it doesn't inundate them with more complicated training and all these complicated devices. It's a nice, simple, easy, color-coded system that has a tremendous amount of science, it seems, behind it to get it to this level, because usually the more simple it is, the more development went into it to get it to be to that point. So this is amazing.
And here's our goal is that I know we're in North America, we want 20/20 vision. But in the developing world, our goal is 20/30. 20/30 gives incredibly good quality of life. So now what you've done is, and we found that people that come in needing glasses, now there's other eye conditions that will be screened for. It might something as simple as conjunctivitis, pink eye, or pterygium. But those will then get put off to the side to the family doctor, who we almost always have a family doctor working in the clinic with us. And we find that 92% of the patients will walk away with 20/30 vision or better. Now that 8% are the ones, when at all possible, we have an optometrist on site or coming in once a week or once every 2 weeks. Those are the patients that see the optometrist, because you see in the developing world, there's a lot of places, like I work a lot in Congo. There's one optometrist for every 1 million patients. I mean, you just know that statistically, they're not going to see an optometrist. Now, the few optometrists we do have, they're only going to see the ones who've already been pre-screened by a nurse, who made glasses, who already saw sight improvement, but we want to see better sight improvement. I'll give you a great example. In one of my clinics in Malawi, this is my gold standard. I'm working really, really well with Luxottica's One Sight. I have to say, thumbs up to them. They've been fantastic to work with in Africa. So let's say we have our patients. We're running clinic 5 days a week in the refugee camp, in Zalika refugee camp. The patient comes in, they see 2100. We get them to 2050. Hey, that is already, like, they can now cross the street without being hit by a car, right? Now, it's not well enough that they should be driving a car or those type of things, but we've now had them leave for $4, seeing well enough that they're safe. That person gets the ticket for when they know that Dr. Innocent is going to be coming next Friday. And only those people who've got the ticket get to see Dr. Innocent. Dr. Innocent wants business. He's a young optometrist who cares, but he's got bills to pay, right? We've made an agreement with him that he will use our frames and our lenses. When he comes back, that person will come with what their prescription was, and they'll see him, and he will talk to them about how he can grind their frame, their lenses, so that they can see 20/30 or 20/20. And it'll cost about $20, $25 for them. He's made more business, he's doing social justice, and he's bringing eye health to the clinic in the refugee camp. So really, we're intended to be working with the Optometry Association. This is not a replacement of. And then best of all, it's left behind with the teams so they can continue to use it in a sustainable way, in a way that the already existing healthcare is able to do it, and we're able to achieve really high good results with it.
And it's like you point out too. It's having something existing there that the healthcare can use, because it has to be that hybrid approach. I don't think it could ever necessarily replace it, just because of the fact that we do have underlying eye conditions, and it's not just always the refractive error, right? But at the same time too, if you think about it, there's something we in the States, and I'm sure you may have heard this throughout your time in the eye field, but there's a difference between 20/20 and 20 happy. Taking somebody from 2100 to 20/20 is going to make them feel like their world is uninhabitable. It's going to be such a drastic shock to them to get used to those glasses. I mean, you're talking headaches and tension headaches, eye strain issues. So stepping them into that point to where they can understand, okay, it can be better, because that's another hurdle, is the ability to let them know, hey, it can be even better than this, and then they take that initiative to be able to do it. But in the meantime, you're putting them in a more safer space by at least allowing them to function in their environment and be able to do the things they need to do in a safer manner. So that is really awesome. It kind of defeats my next question of improving access to communities, but what can we do, and what's currently being done, and how can we reinforce these efforts to get more quality of life back into the hands of these folks?
Well, first of all, number one, we're still a very new organization. We are now finally at the spot where if you said, hey, Greg, I want to put in an order for a few thousand glasses with the kits, and they come out to about $4 per pair. We sell in bulk to the groups. That's, of course, why it's cheaper when you sell in bulk. We've got our stats down. The bigger the kits are, that it works. But being known, see, we're a different type of charity and nonprofits. We're really the guys that invented a tool to be added into already existing nonprofits. So really, it's sort of like we need to be known. So let's say there's a medical group that's going into a refugee camp in Kenya. This is what they need to bring along with and alongside all the other things they're doing. We need hospitals and community healthcare clinics and schools. I always say nurses are my gold standard that I shoot for. This is what we created it for. But a very close second are teachers. Teachers grasp this, and they know how to tell the students and the parents how to get in line even better than the nurse. It's actually really good.
Yes, they do.
This to me in the developing world has the potential to be in every rural hospital, every larger, headquarters school. Like they often have the high school is sort of like the draw for 4 or 5 villages. Having this available and in conjunction with the local hospital and the teachers, you will be able to solve 92% of the kids that'll see the backboard from the back of the class now. And on top of that, we've worked with the UN with what they want from us, and they've said we want safety glasses. I don't mean like the safety shields around. We're talking safety as the lens drop ball test on it, that the lenses that we have come with it are the same quality as what you'd buy for safety lenses in your safety shield glasses. So it also just improves eye safety for people. I've got dozens of stories of mechanics who we made them glasses, and they came back to us before we left, where they said, hey, I need new glasses. I broke these at work. And they come and they've got a grinder disc that blew up in their face, and they've got marks all over their face, and they've got, indents exactly where their eye would have been from that grinder disc blowing up. So this has got so many avenues for eye health in the community. So letting the people on the ground know we have a tool that is ready to just be added right in to what they're doing.
That is amazing. And it's very true. I mean, after working in, like I was telling you before a little bit, I've worked in, cornea departments. I've worked in glaucoma and in optometry and ophthalmology. And yeah, there's many a times when people aren't using safety glasses, they're using the squint your eyelids method. And then we're sitting there for a week trying to get the rust ring out, and we feel bad because, you don't know if it's going to cause a scar. You're worried about that when all it would have required is a pair of polycarbonates or something, and
You're
it would have been
100%
covered.
right. That's exactly who we're thinking of.
Yeah, and it's very true that, going with the nurses and the teachers, that's a great idea, because when I was studying medicine in the Caribbean, the teachers were very integral when we would go to classrooms and we would do, like, heart screenings for murmurs and whatnot, of being able to not only just help us translate to the kids and understand what we needed to do and what they needed to do from a communication standpoint, but also to help make the kids less scared. And if they were able to do it as their teacher, if we were able to train them that, because we would have had something that would have allowed them to understand it to this level, I'm sure that they would have been much more on board and a lot more at ease, because that's a huge thing with healthcare, and especially when somebody's poking around your eyes. Your eyes are one of those things where you're like, don't touch them. So it gets rid of that false sense of, like, I need to put a wall up and protect myself because they're just going to be correcting my vision and I understand what they're doing. It's not just put this on and here it goes. That's awesome. That's
You're
awesome.
100% correct. It's actually the teacher who often brings the whole community at ease. When I come into a community, the first group that I check and I connect in with is the local healthcare association. Usually it's a head family doctor giving oversights to all the healthcare. And the very second one, if I can have them even meet at the same time, the principal of the local high school. Those are my two biggest allies. They both completely grasp what needs to happen, but they've got their different strengths on how to make it happen. And more people are willing to take a pair of glasses from the principal or the high school teachers than anyone else in many of the communities, because they're often the most trusted people.
Mm-hmm. And often they've built that level of respect in the community that, whatever they're approaching you with is not going to be something to harm you, right? So this is I'm really excited to see where all of this goes and how we can help out more, and how we can access better eye health and better vision to developing communities. It's a huge part of something I wanted to get involved in my previous job, because we used to do things with Special Olympics and Lions Club and certain things like that. And of course, I was, after in the training department, I was that kind of go-to person, and I like being able to help solve these issues and get the word out. What can people do to get more involved, more educated, and help out in any ways?
Okay, so one, I already know there's a lot of family doctors, nurses that like to go on short-term trips using their skill sets as they go to work with, whether it's Doctors Without Borders, Mercy Hospital ships, and all of those type of things. One, this would be a fantastic tool to take alongside your already existing project, and it can be inserted straight into. So if they want to get directly, they can come and approach us at Global Vision 2020, so gv2020.org, and they can purchase a kit to take along with them. And it is a great tool. I just had a couple of teams go up from Edmonton, Alberta, and it was a family with a family doctor, was the dad, mom was a nurse, and they took their 14, 16, and 10-year-old or something along those lines, and they just sent back amazing pictures of where they had planned to go with a medical agency. And they were able to insert their kids into helping, because there's all sorts of work, whether it's snapping the lenses in or having the person standing by the eye chart going through the tumbling E. They came back and said that was the best trip we've ever done, and they completely changed the lives of people, and they left the kit behind for the community to use. So that's one where people can actually actively add this into service projects that they're passionate about. Two, let our name be known. If you're looking at North America, the area that I need the best connections into are First Nations, both Canada and the United States. I know my statistics are that there are a lot of very rural areas, whether it's in northern Canada or deep down in the south in Arizona and New Mexico, where there's people that are far away from having any place to get their eyes tested. We can work with First Nations health authorities. I just need an introduction. And here's the way it is. Unless you get an introduction, it doesn't go anywhere. You can say, well, why don't you email these and go to the group, info at this and info at that, and send out emails. I know this. Those never get responded to. Those go into a trash bin, like $4 prescription glasses. What a scam. No, you don't understand. We've worked 15 years starting with the U.S. military to get it to this spot. It sounds too good to be true. This isn't a solve for everything. This is just a fantastic tool to be added. So somebody out there says, hey, I want to give you an introduction to First Nations Health Authority in the United States or in Canada. I would love that. And then third, we would gladly take donations. I specifically have projects for the groups that I help work with in Congo. We are relocating refugees. This is something I'm hugely passionate about. We're relocating refugees who have been in refugee camps. Congo went through a horrible civil war that's mostly over. There's still some areas where it's hot, but most of the country has settled down. There are over 8 million refugees living outside of Congo. I have been working with healthcare workers that have been refugees, doing it in their communities in countries like Mali, Zambia, Zimbabwe. And we've started to move them back to Congo, to the safe areas, and helping them get their first kits that we pay for and I fundraise for, so that they can relocate their family back to their country that they have citizenship. We set them up next to a mine. The Canadian mines and the Swiss mines have been actually really good to work with. And now that mine is excited because they've got a eye clinic that's set up on their facilities, giving their workers a pair of glasses that are safety, and their truck drivers are a lot safer too. So we would gladly take donations if people feel compelled. We can give in Canada and the United States tax receipts for those things.
Awesome. Awesome. Well, hey, I'm really excited. Hopefully we can have you on again in the future. I'm really curious to see how things are going to go. And obviously if there's anything, that our audience can do, we're going to try to do everything we can for you.
I've got actually one more. We're growing gangbusters. Mm-hmm. We have the opportunity for an investment for the right investor. And when I mean the right investor, we've been invited on to Shark Tank and Dragon's Den in Canada and those type of things. And we've said, no, we're not interested in that. Like we if there's somebody out there that says, hey, I'd like to talk about being the right investor, we would gladly talk. We're not in any spot where we have to have anything. But we also know that there's potential to grow enormously with the right investor. The right investor that has social justice and sustainability as a huge part of what they want their money invested into. We'd be glad to talk. We've got some great opportunities. We've got an amazing board. We've got board members from Johns Hopkins University, from Harvard, that are on our board. And we're all in this not for money ourselves. We're in this because we're saying this will change the world in an incredible way. It's actually the single biggest economic boost we can do to the whole world. Is there's almost 1 billion people who currently need glasses, are not wearing glasses, and their productivity is hurt simply because of that.
Most definitely. Most definitely. Well, everybody, thank you so much for tuning in today. Check them out on social media if you want to understand a little bit more. I loved seeing all their outreach and the way that everything worked behind the scenes and how people were interacting with you guys. So please check them out. We'll tune in next time and talk to you guys again shortly. Thanks, Greg. I really appreciate your time today.
Thank you.